So when you're looking at the newborn baby's respiratory system and you're doing interventions to support their respirations, you want to make sure, one, we're going to position the baby on its back. We're going to have not a lot of things in the baby's open crib their environment, because we don't want anything to occlude their nose because they're obligatory nose breathers. If they need to be suctioned, and we will suction them if we feel they need this, we're going to bulb syringe suction them first. It's not as aggressive of a technique as it looks. If you're watching a nurse do this, we don't just jab this to this straight to the back of their throat, but kind of we go to the side of their mouth, and you want to avoid trauma when you're doing this to delicate mucous membranes, and we try to do it no longer than 5 seconds at a time. Some babies require deeper suctioning, where we have to suction deeper in the baby's airway. Sometimes you'll see this with babies who are born precipitously or rapidly, or babies who are born by C-section, where they have more moisture and fluid in their throat and deeper in their airway, so they may need to be suctioned with a suction catheter, and we will do this as as we feel we need to support the baby's respirations and their ability to breathe. One of the factors that come into play when you're looking at a newborn baby's respiratory system is surfactant. Surfactant is really this soapy phospholipid that decreases the surface tension and allows the alveoli to stay open and not collapse at the end of expiration. And it really helps and assists with gas exchange. It lowers the inflation resistance that's really needed to open the newborn baby's airway. This substance helps decrease the work of respiration, but surfactant needs to be there in adequate amounts to support respirations outside of the uterus. When the baby is about 25 to 30 weeks in gestation, they start to produce small amounts of surfactant, but it's not enough to support respirations outside of the uterus. But as the pregnancy gestation advances, sufficient amounts of surfactant will be produced. About 35 weeks and on, there's usually enough surfactant to allow and support respirations outside the uterus. We can assess surfactant before delivery. They can do an amniocentesis, which under the guidance of ultrasound, they will insert a needle into the uterus and aspirate a small amount of amniotic fluid, and they will look for key ingredients. They're looking for lecithin, sphygmyelin. Those are key ingredients into the development of surfactant, and if you have a ratio of at least 2 to 1, or greater, then there is enough of this key ingredient to make surfactant, so their surfactant level is adequate. But if their volume of lecithin, sphygmyelin, or their LS ratio is lower than 2.1, if it's like 1 to 1 or less than 36 weeks, they may decide to give mom some corticosteroids. An example of this would be betamethasone to jumpstart the production of surfactant. So again, you need adequate amounts of surfactant to help the alveoli from collapsing at the end of expiration. When you're learning about the respiratory status of the newborn baby, one of the other factors that you have to take into consideration is the fluid that is in their lungs. Babies in utero secrete lung fluid. It's secreted by the lungs, and it's in the amniotic, they have amniotic fluid that they are bathed in, and they'll have lung fluid in their airway and their lungs, and fluid in their trachea and in their mouth. That fluid will need to be replaced with air after birth. The process of labor actually helps expel that fluid. About a third of the fluid is expelled during the birth process and removed, and the remaining fluid is absorbed by the newborn baby's lungs. However, some babies develop a condition called transient tachypnea of the newborn, when not all of the fluid is absorbed or expelled. And what will happen is, at the time of delivery, the baby will have transient signs and symptoms of respiratory distress. They will have grunting, flaring, retractions. They will have low Spo2 readings, They will, really have some difficulty with respirations. And when they do a chest x-ray on the baby, it's going to show moisture in the lungs. This really affects more C-section babies or babies that are born precipitously. They don't get that thoracic squeezing of their chest. Usually they just need supplemental support. They'll be sent to NICU. We'll give them, give them some extra O2. We'll keep them warm. They may have to have some, other small interventions that are done to support the respiratory system. And during that time, the remaining lung fluid that's in their lungs becomes absorbed, and then the symptoms of distress will go away. When we talk about the characteristics of the newborn respirations, remember, normal respirations are about 30 to 60 a minute. We talked about diaphragmatic synchronization of their chest movements. You should have equal rise and fall. You don't want seesaw types of respirations. The newborn baby's initial breaths are shallow and irregular, and as the baby gets older and they develop more, their breathing will become deeper and more regular. But those periodic pauses that the newborn baby takes, as long as it's not anything greater than 15 seconds, it's completely normal. Again, they're obligatory nose breathers for the first 2 to 4 weeks of life. You want to remember the reflex to open their mouth and start breathing after if their their nose becomes occluded. That will develop later. It doesn't happen right after birth, but this can increase the risk of sudden infant death syndrome, which is known as SIDS. So we really want to encourage babies to be allowed to sleep flat on their backs. We don't want anything in their environment that can occlude their nose or their airway. And keep in mind, crying is good for their lungs. If we have to assess their Spo2 readings, we will do so. It will look like a little band-aid with a light on the foot or the hand, but this is how we would assess their Spo2 rates. Silverman-Anderson index grading looks at retractions and the symptoms of respiratory distress. This comes back again in high risk, but so that you understand this, it uses kind of an assessment scale, very similar to, remember how I told you about APGAR score? It uses a similar approach where you have criteria such as retractions in the upper chest, the lower chest, where are they? Do you see them by the xiphoid? Do you have where they're narrate or flaring? And do you have auditory expiratory grunting, or do you need to hear it with a stethoscope, etc.? Basically, you grade each of these areas, and the lower the number, the better off your baby. The higher the number, the more in respiratory distress your baby is. The next thing we're going to talk about is thermoregulation. This is also a very important adaptation that newborn babies have to make. There are several factors that can influence the ability of the newborn baby's ability to adapt and to regulate their own thermoregulation needs. You have anatomical factors as well as environmental factors. Anatomical factors, you want to remember, if a part of the baby's body is exposed, that's a larger surface area of exposure compared to yours or mine. The newborn baby has less adipose tissue, their skin is thinner, and they have less subcutaneous tissue as opposed to you or I or the older child or adult. In addition, their epidermis is thinner than yours or mine, their epidermis. Also, their blood vessels are closer to the surface of their skin. Babies are born wet, so fluid on the baby's skin will drop their temperature, and babies don't shiver when they become cold. They will actually start to oxidize their glycogen stores and their fat stores, and that can cause them to run into some problems. In addition, of the stores they have, they're in limited supply. They have limited supply of glycogen, limited supply of fat, and limited supply of glucose. And babies can't communicate their needs. They can't say to the nursing staff or to their parents, I'm cold or I'm hot. Can you, wrap me up some more? I'm chilly over here. They can't do that. When you look at the environmental factors, the ambient temperature of the room in which the baby is born is a lot cooler than the intrauterine environment. And in any room you have air currents. You have lower humidity and faster air currents than inside the uterus. There's no air currents. So there's different mechanisms as to how babies lose heat. You have conduction, convection, evaporation, and radiation. And these are 4 different ways that the newborn baby can lose heat. The first is conduction, where the baby comes into contact and direct contact with something that is cooler than they are, such as a cold scale, or they're laying on an object that's colder than they are. You can have convection, which you have the flow of heat or the flow of heat from the body surface to cooler areas, or air that is blowing over them, such as if the baby is next to an open door or an open window. You can have evaporation, which is the loss of heat when liquid is converted to a vapor. So if the baby has moisture on their skin, it will cool the baby's body temperature. And then you have radiation, where the baby is not directly in contact with something that is colder than they are, but they are in close proximity to it. So an example of this was if the baby's crib was next to a cold exterior wall. So these are the 4 main mechanisms of heat loss in the newborn. Again, you have radiation, convection, conduction, and evaporation. Newborn babies, term newborn babies, have brown fat, and it's called brown fat because of the fact that it has blood vessels that run through this fat, and the blood vessels, the presence of those blood vessels will give this fat its characteristic brown color to it. This fat is found in term babies, and it's found around the sternum, around the scapulae, around the baby's kidneys. Those are typically, and the baby's sternum. And so this is found only in term babies. Preterm babies haven't even developed this highly vascular fat, and this fat is, we think, is important for the baby to be able to meet its metabolic needs as it's transitioning. However, if the baby becomes cold, instead of shivering, they will start to oxidize or burn this brown fat. Excuse me. So when you're looking at the newborn baby, you really want them to be in a neutral thermal environment, not an environment that's too hot or too cold. Hypothermia can cause them to run into problems, as well as hyperthermia. When you're looking at hypothermia, you can have situations such as vasoconstriction, can cause increased metabolic rate, increased muscular activity, and they can go into that non-shivering thermogenesis where they start oxidizing that brown fat. You can have when a baby is hyperthermic, where they're too warm, they can also run into problems such as vasodilation, increased O2 consumption, and increased fluid loss. So when you look at this, again, baby has a large surface area, limited insulation, limited ability to sweat, and you really want a neutral thermal environment, which is this balance between heat loss and heat production. When they go into non-shivering thermogenesis, you got to remember the newborn baby doesn't shiver, and what so we want to talk about this brown fat. Brown fat is a special kind of highly vascular fat that's found in term newborn babies. It contains a lot of, or an ample supply of blood vessels, which cause that fat to become brown in color because of the presence of those blood vessels. And it's found primarily in the back of the neck, in the near the baby's axillae, around the kidneys, the adrenal glands, and the sternum. So term babies have this brown fat, but preterm babies haven't even gotten to develop this fat yet. And we think this fat is there for the newborn baby to meet its own metabolic needs as it transitions from life inside the uterus to life outside the uterus. You really want the baby to be in a neutral thermal environment, one that is not too warm or one that is too cold. So if babies experience hyperthermia, they can run into problems, as well as hyperthermia. When they experience hypothermia, they can go into vasoconstriction, increased metabolic rate, increased muscular activity, and actually go into non-shivering thermogenesis, which is when they start to oxidize that brown fat, and we don't want them to do that. as well as babies that are too warm. If they're in a hyperthermic environment, that can cause them to develop vasodilation, increased O2 consumption, and increased fluid loss. Excuse me. So when you're looking at the newborn baby, there are a couple of factors to consider in their risk for overheating. Large body surface area, they have limited insulation, a limited ability to sweat. And when you look at thermoregulation, it's this balance between heat loss and heat production. And we really want to make sure that the baby is in a neutral thermal environment, one that's not too warm and one that's not too cold. Babies can have overheating or hyperthermulation for a couple of reasons, such as we put them under the radiant warmer and we forget about them, or maybe they're experiencing they experience drug exposure, which is called neonatal abstinence syndrome in utero, and they're going through active withdrawal, so they may have a fever, or there can be some infectious process. There are a variety of reasons for the baby to also have issues with hyperthermia as well. When you talk about the non-shivering thermogenesis, this is not effective in heat production for the newborn baby. The baby's metabolic rate increases in response to falling skin temperature. They begin to oxidize that brown fat to try to produce heat, and this causes the baby, even though it may generate a little bit heat, it's really not an effective use of the baby's body to effectively generate heat. And they can actually go into what's called cold stress. Cold stress causes an increase in their metabolism to try to produce heat, but it requires the use of oxygen and glucose. And the baby will become hypoxic because the O2 that they're taking in from their environment is being used primarily to try to generate heat and not being used to meet the oxygen needs of the tissue. In addition, cold stress can decrease the production of surfactant, so it can increase the baby's risk of developing respiratory distress syndrome. In addition, the glucose that's needed to use for the baby to meet its own metabolic needs, those glycogen stores become depleted because those glycogen stores get converted to glucose in order to try to meet the baby's body's demand to try to make heat. So they can become hypoglycemic as well. So cold stress really decreases the newborn baby's ability to adapt to the external uterine life environment. So when you look at this effects of cold stress, it can lead to the increase of O2 consumption. It can cause what you'll see in the newborn baby is an increase in their respiratory rate, so they will become tachypnic. And in addition, even though their respiratory rate is increased, there is a decreased amount of O2 that's taken up by the lungs. So that can cause pulmonary vasoconstriction, and it leads to not as much oxygen being used to meet the needs of the tissues, but instead to try to generate heat. So they'll have a decrease in their PO2 level and their pH level. They can actually develop metabolic acidosis just because they are not kept warm. So you don't want the newborn baby to become cold. It can increase their O2 needs, decrease surfactant production, increase the baby's risk of developing respiratory distress syndrome. They can become hypoglycemic and acidotic, and also jaundice, all because they're not kept warm. So I have a joke with students in my class. I tell them, you don't want any ice babies. We want them warm. Hyperthermia is equally problematic for newborn babies. The neonatal hyperthermia is defined as a body temperature that is above 37.5. And this increase in body temperature can cause an increased need for O2 and glucose. It's usually secondary to some problems, such as we put them under the radiant warmer and forget about them, or we've wrapped them in so many blankets that they're too warm. But it can be secondary to other problems, such as sepsis. They can have some type of metabolic syndrome, or they've been exposed to drugs in utero and have a neonatal abstinence syndrome because they're experiencing withdrawal, or they have some type of infection that they maybe got from their mom at the time of delivery. So when you look at the effects of hyperthermia, it can cause also an increase in their metabolic rate. It can increase in their O2 and glucose consumption. It can increase the loss of fluid, especially insensible fluid loss that we can't measure. And they have limited sweating ability because they have immature sweat glands. So some of the things that we try to do to try to prevent this is if we have the baby under the radiant warmer, we're going to set the controls to try to vary the heat according to the infant's skin temperature. So we'll set those alarms and we'll try to maintain a neutral thermal environment. There are different ways we can warm the baby. We can use a radiant warmer. We can, as soon as the baby's warm, we're going to dry them off with warm blankets, and we're going to put the baby on mom's chest. We're going to do skin to skin care and cover both mom and baby with warm blankets to help generate heat. And remember, mom's body is warm. It's going to act like a heating pad to that baby. We also will wrap them in either blankets and or sleep sacks. Sleep sacks are really evidence-based nursing practice where we use these sleep sacks, and what we have found by research is actually these help the baby hold their temperature more evenly. They don't develop the hot pockets or cold pockets that they can sometimes when we use just blankets. So a lot of facilities have gone to using sleep sacks for the newborn babies. Some babies, because of their transitional issue, maybe they're premature or they have some type of complication, are struggling with holding their own heat, and so they because of their running into problems with thermal regulation, they may need to be cared for in an isolette. An older term for this is an incubator, but it's actually a device that warms the air that is circulating around the baby and helps keep their temperature more evenly regulated. So it's for a baby that can't hold their own temperature in an open crib. When you look at the warming chain, there's some things that you're going to see that we're going to try to do to promote keeping the baby warm. One, we want a warmer delivery room. We don't want ice cold delivery rooms. We want warm rooms. We're going to immediately dry the newborn baby off with warm blankets, and we're going to initiate skin to skin care. If mom can't do it, like let's say this is a C-section, they'll do skin to skin care with dad or the significant other that is there with mom. We will initiate breastfeeding early on. We're going to wait until the baby's temperature stabilizes to postpone that before we give them a bath and drop their temperature. We're going to use appropriate clothing and bedding for that baby and try to keep mom and baby together. It's called rooming in care. If we have to transport them, we're going to put them in a warm isolette while we transfer them to, like, maybe if they have to go to NICU. And if they have to be resuscitated, and during the process of resuscitating them, we're going to still try to keep them warm so that they don't go into cold stress. And we do a lot of training of nursing staff and those that are providing care for newborn babies to help them understand the need for thermal regulation and keeping a neutral thermal environment. There was some research that was done by Waldron and McKinnon in 2010 that pointed out some evidence-based practice points that are still relevant to today. One of their key points is newborns are acutely vulnerable to the harmful effects of thermal stress. Two, we have to prevent damaging heat loss for preterm babies as we're working on them at delivery, and that's still a problem that we have to continue to work through. They also pointed out that more research needs to be done to develop an evidence-based protocol for decreasing heat loss during a neonatal resuscitation, and that the fourth point is that hypothermia is not good either. Hypothermia can be associated with poor neurological outcomes and has stimulated research into therapeutic hypothermia. So they're saying basically a neutral thermal environment is most important. Don't assume just too warm is better than cold. It's saying that that's problematic as well. So So here's a chance to apply. A nurse in the labor and delivery room is assisting with the delivery of the newborn infant. After delivery, the nurse prepares to prevent heat loss in the newborn infant resulting from evaporation by A, B, C, or D. The correct answer is C. So now we're going to go into the hematological adaptations of the newborn baby. The newborn baby blood values are 4.8 to 7.1. Your hemoglobin is 15 to 24. Hematocrit 44 to 70. White blood cell count is 9.1. Basically, think of 9,000 to 34,000, and platelets 100,000 to 300,000. There are some benefits to delayed cord clamping. There's research, especially in 2010, that came out to say, listen, there are benefits here. I used to see this practice a lot with midwives. We still do, where they will wait to the umbilical cord stops pulsating before they cut it and clamp it. And what they found when this research came out is when they do that, it allows for the blood that the baby has in the placenta to return back to the baby. And there are benefits in that. It decreases blood loss, decreases the need for the development of the baby developing anemia. It decreases the need of transfusions later in life, and the baby gets a transfusion of stem cells and clotting factors, and it decreases the risk of the baby developing some problems later on, such as respiratory distress syndrome, intraventricular hemorrhage, and late onset sepsis and eye diseases. When you look at the hematological adaptations, newborn babies, their average blood volume is 80 to 85 milliliters per kilogram. If the umbilical cord remains unclamped at birth until it stops pulsating, they'll have an additional 75 milliliters of their own blood that is given back to the baby from the placenta. There are some controversial, like some physicians feel that adds to the workload of the baby's heart, but there are benefits to doing that. So we feel that the benefits outweigh the risks. Newborn babies get an IM injection of vitamin K because their bowel is sterile and they don't have intestinal flora to synthesize or develop clotting factors. They will, and when they start taking in oral feedings and developing bacteria in the gut, in about 5 to 10 to 12 days, they start to develop enough bacteria in their gut to develop clotting factors. But in that short period of time, they're increased risk for bleeding. So we will give them a one-time IM injection, and it goes into the vastus lateralis muscle of the baby's leg.